Everybody for joining me. I love giving this talk once a year for PHAN on the state of health in Nebraska. I'll try to stay true to Julie's characterization of this will be an exciting talk. I'm not quite sure yet if it will be, but we'll see. Okay, so I actually wanted to start. Please start. Okay. I always like to start with thank yous as opposed to putting them at the end of my presentation. So I'm very grateful to Dr. Brandon Grimm and Marissa Rosen, who shared a number of slides for this presentation, to Miss Katie McCarville. She's with Sync Health, and I'm going to talk a little bit about the Make America Health Tech Great Again initiative. And she shared some slides about that. And to Ms. Alexander Todd, one of our amazing alums, who's a health policy analyst and helps bring all these slides and presentations together for me. So I want to start in a good place and end in a good place where health in Nebraska is concerned. And I thought I'd actually start with this. So U.S. News likes to rank all sorts of things, and based on all sorts of criteria, right? It seems they don't really do news anymore; they just do rankings. But a recent review suggested that Nebraska was number fifth in states, and I love that, because I love Nebraska and I love living here. So they rank Nebraska as the fifth best in their overall ranking in states. You'll see it's sort of a composite of all sorts of different things, crimes, economy, education, et cetera, et cetera. But you'll see they rank Nebraska 23rd, which is really interesting as we look at what America's public health ranking says, what our public healthcare status is in the US. Otherwise, Nebraska does really well in infrastructure and a number of other areas, does not do as well in economy. A lot of this has to do with the brain drain from this state, but I think that's a different presentation than this one. So today we're going to talk about four things. I'm going to talk about the state of health in Nebraska. I'm going to specifically try to focus a little bit on rural health challenges in Nebraska. Talk about sort of how we transition what public health look like to where I think public health is going. And so these will be my questions to you toward at the end of the presentation. And then the good life, forged by trust. So how do we move forward with public health? So state of health in Nebraska. So let's look at the most recent America's Health rankings. This is the sort of yearly rankings that come out from the United Health Foundation. And the bad news, unfortunately, is that we've sort of gone down in our ranking again. And so we're now ranked 20th in the United States, which incidentally is not that off from the 23rd that we ranked by the United News and Report. So it's sort of pretty consistent. And as you can see, we started out 1990 as ranked fifth in the nation. I'll tell you a little bit later why we've had this sort of precipitous drop since essentially the mid 2020s in our health ranking. But it is disappointing because we were, until I guess 2015, ranked 10th in the nation, right? And then pretty consistently around 10th in the nation. So what are the strengths? Low prevalence of non-medical drug use, low prevalence of frequent physical distress, high volunteerism rate. But we have challenges, as we always do in this state, with excessive drinking. Obesity is going up in this state, and we have a low prevalence of adults with a dedicated healthcare provider. The key finding this year, and remember, they look at a number of different composites to put together the health rankings, including the determinants of health. And Nebraska traditionally, I believe, has been amongst the lowest states for unemployment. And that's ticked up over the last couple of years from 2.3% to 3.4% unemployment in this state. And depression has also ticked up from 16.2% to 18.8% of Nebraskans. Good news, smoking is down to 12.2% in this state, which is fabulous from rates about over 30%, I believe, at some point. And physical inactivity. There's fewer Nebraskans that are physically inactive. So now it's about 20% of Nebraskans. It was about 25% of Nebraskans. So there's some pieces of good news uh, in this sort of decline in our health rankings. Income inequality is not that bad in this state. Severe housing problems, insufficient sleep, drug debts. We're actually, I believe, have the fewest drug debts in America. Not that drug debts aren't going up in the state, but still the fewest in America. Uh, the one of the major reasons why we've dropped, we used to have one of the best childhood immunization rates in America, and now we have pretty much the worst or close to the worst childhood immunization rate in America. These two have not changed in my 11 years here as your dean. We always rank in the bottom five when it comes to excessive and binge drinking, and we are amongst the most inequitable states uh, in the union. A lot of this work in these two categories will require significant legislative changes, in addition to public health action, but do require significant legislative changes to try to tackle these two issues. Let's talk about vaccination rates. So, as I said, once upon a time, and once upon a time means when Ali got here a decade ago, uh, we had one of the highest immunization rates in America, and we were actually quite proud of it. Well, that's dropped off, and you will see versions of this slide by county because there are significant disparities by county, and obviously this makes those disparities clear, but this isn't really a good way to show it to you because it's probably a much better way to show it to you is by individual school districts, because even within a county that may look like it's doing quite well, you will have individual school districts, neighborhood census tracts that will have market discrepancy between rates to an adjoining school district or county or census tract. And this is where hyperlocal data really is important. Now, this decreasing vaccination rate across Nebraska worries me because essentially what it makes us is South Carolina, right? So last year, quick update, measles. This is about measles. We eliminated measles in the United States in the year 2000, which means no essentially domestic cases of measles within the country. That didn't mean that if somebody came from outside the country and had measles and you had a handful of cases, that didn't count against your elimination status, right? We can't control measles all over the world, but we had it controlled here in the United States. And then last year, we've had the largest measles outbreak ever. In the last 25 years, with almost 3,000 cases, three deaths, unprecedented three deaths uh, of measles, an undetermined amount of people who got brain swelling and pneumonia and other complications from that. And this year, we moved, so that was the outbreak there started in West Texas, and small community unvaccinated. The current community, currently the same issue in South Carolina, starting in a community that's unvaccinated and unprecedented. I think we're, let's see, outbreak, South Carolina hits 876 outbreaks. I think at this point, I may have seen something recently, there may be over 900 odd cases in South Carolina, and disease is continuing to spread across the United States. You see this in the sort of a graphic, and I like this graphic actually, graphic way to show it to you on the left that you can see after MMR was introduced in the United States in 1971, how dramatically we've decreased cases in the United States. So vaccines work without a doubt, and they work by training your immune system. So, as I like to say, you don't have to do the whole getting sick and dying part of infectious diseases. Access drinking by state. This anybody who's here heard me give this talk the last 3, 4 years. I this no, it's not. I promise you, it's not the same slide. I update it every year, but it's the same message every year. Over 20 to 25% of Nebraskans, women or female, uh, binge drink in the last, at least once in the last 30 days. And same thing's true for excess drinking within this state. Do I have another alcohol slide for you? Or I'll tell you a little alcohol story if I can. Uh, yeah, I'll tell you my little alcohol story on this slide. So, as a good Muslim boy, I love Lent, which is coming up. And the reason I love Lent is I get to go to fish fries here, which is not something that we did where I grew up in Brooklyn. Um, and so I show up at my first fish fry, North Omaha, biggest one in the city, if not in the state. And it's like it's blocks before you can get into the church. And people show up with their coolers and they drink all the way until they get inside. And then they get these cheap pitchers to drink some more. And I'm like, why do we call this a fish fry? And that's where I learned about the alcohol culture in this state, and which is going to require legislation and a lot of public health work, to be honest with you, to address. In this slide, you'll see that the rates of excess drinking are there significant disparities by county. You'll see some version, as I said, of these counties or slide or county or counties or district health department slides for the rest of this talk because I like to make that point about discrepancies and why sort of you need really good localization and data at your level to make action, to think about what actions look like within your communities. But yes, there's a lot of discrepancies, but it's still a lot of alcohol drinking that occurs across this state. Premature deaths, also an issue in this state. What is it? Our life expectancy is essentially consistent with the state life expectancy. I don't think the national life expectancy. I think the real story is the significant discrepancy you see. Again, a key theme for what happens in this state that you see across the state, depending on what county or district health department that you go to, and discrepancy within states. So here, even within Douglas County, where I'm located, currently, you can see over a 15 to 20-year life expectancy difference. That's 15 miles, 20 miles drive, and discrepancies obviously between urban and rural areas that we see here within the state. This is another example to get at that issue of the disparities and significant disparities we have this state. In this case, specifically around racial disparities. I like to talk a lot about infant mortality because we know we can dramatically decrease infant mortality based on work right here in the United States, let alone work globally. So Nebraska's infant mortality is ranked, I think we're ranked 14th or 15th in the nation with a significant disparity. So if you're a black baby born in Nebraska, you're almost two times more likely, 2 to 3 times more likely to die than if you're a white baby born in Nebraska, which is pretty absolutely stunning when you think about it, right? So I'm a pediatrician. I've been in the delivery room, and when that little baby pops out, I never think, oh well, God, you're 3 times more likely to die than the other little baby that popped out a minute ago, just based on your skin color. So that's kind of not just it's depressing, to be honest with you, and unconscionable in our modern society. The good news is in rural areas, our infant mortality in Nebraska is actually better than the national infant mortality. So it's not always a function of the disparities may be more rural than urban. In some cases, it may be more urban uh, than rural. It just depends on the condition and what's going on and what the access to healthcare in that area is and what the quality of public health is within that area. Here you see it more clearly. White infant mortality in Nebraska. So we have, I believe, about 25,000 deaths, 25,000 births every year in Nebraska. White infant mortality is 5.2 per thousand. Blacks is 12.5. The national goal, 2030 goal is, I believe, 4 uh, um, deaths per 1,000. And good time to remind you that parts of the world get to 1 death. So where we want to go in the United States is 4 times higher than where many countries have already achieved. Nice to see when you look at the leading causes of death in Nebraska that COVID, like nationally, has come off of the top 10 list. But the key things killing people in Nebraska is no different than what's essentially killing people across the United States: heart disease, cancer, chronic lower disease, lower respiratory disease, and accidents, usually in the top 4 or 5 of reasons that people die within the state, and for us to think about where should we be focusing our prevention efforts to try to make a difference is where people are most likely to have premature deaths. So you're going to die regardless, and we all know that. You just don't want to die prematurely, and you want to die as healthy as possible. A linker, something that links the top two causes of death, heart disease and cancer, is physical inactivity. And so this gives you an example of the disparity we see across the state in terms of physical inactivity. The other thing that would link across this is obesity, which I don't have a slide for obesity. Okay, same thing for obesity, links the first two. So there's a couple of common risk factors for the leading causes of death in Nebraska that if we could tackle them, we actually could have a dramatic, oversized impact by trying to tackle some of those risk factors. And this is, since I'm talking about the state right now, this is an interesting uh, feature of the state that I wasn't really aware of until recently, which is we have the highest Parkinson diagnosis rate by state. And there is Dr. Ellie Rogan and others have looked at this here in Nebraska, and they believe that this may be linked to pesticide and herbicide usage uh, within this state. So this was something interesting for me about having the highest rate of Parkinson's disease. All right, so that was at the state level. Let me move now to the rural health challenges part that I want to talk about. And again, I want to start with good news, right? So this is a survey done by, I believe this is done by Extension at UNL every couple of years, 4 or 5 years, looking at rural Nebraskans. And the good news was in 2025, rural Nebraskans were pretty optimistic about their current situation compared with 5 years ago, with over half believing they were better off. They expressed more satisfaction with their quality of life, general standard of living, and job opportunities, and mental well-being described as good or excellent by 86% of people. So it's nice to know that, and I'd like to keep emphasizing this mission, all the good news there is here in Nebraska. And here's a nice good news story about the status of health, or at least the perceived status of health of our rural Nebraskans. And these rural Nebraskans in the same survey also had more confidence in the presidency than they had previously. Yeah, it looks like these surveys are done every 4 years. Uh, um, that said, they had very little confidence in many other national institutions. I'll share. The reason I'm making that point is I bring that up a little bit later when I talk about uh, trust. Uh, oh wait. All right. I'll let. Hold on. No, I do want to go back to that. I don't know how to go back. The reason I know there was a reason I wanted to put this in here. This is about confidence in public safety agencies and local institutions. So this is to you, right? The reason this is here is this talks specifically to you at the local health department level. People trust you. They know you. They trust you. So while they may not necessarily trust what's coming out of Washington, they trust you. And I would like us all to lean into that, especially you to lean into that as you think about improving health within your communities, because you come from a great place there of trust already within the community. And how do you leverage that and how do you increase that? Um, all right, so now that said, all the good news, uh, let's talk about how some of what's going on in rural health is impacting us at the state level, and I want to talk about maternal and child health. So, getting adequate prenatal care seems to be the one of the largest predictors of final outcomes for babies. And you'll see as we've transitioned over time, there's more and more areas where moms are not getting adequate care, and we'd like to move in the other direction of moms getting care earlier. So in Nebraska, if you're a Medicaid uh, patient, I think the average gestational age of first visit is somewhere around 15 to 17 weeks, and I'm not a real doctor anymore, but I don't think that's in the first trimester, and definitely ACOG. So those the Association of OBGYN um, folks, they'd like people to be seen within 10 weeks. So that's the goal, is for if you're pregnant to be seen by your provider within 10 weeks. And the critical reason for that is that's where all the preventive discussions happen with you about do's and don'ts, and that's also where the risk stratification happens to say, oh, you're going to be fine no matter what happens. You and your baby are going to be fine, or as opposed to, wait, you have risk factors, so let's make sure that you get extra care or get triage to a high risk OBGYN. So that's why prenatal care is so important. Now, a big part of the discrepancies in rural Nebraska is making sure that we can address their workforce needs. And again, there's disparities in workforce needs. So while I can show you data that says, by 2030 we will have an increase in total physicians, physician assistants, et cetera, et cetera. By 2030, we will also see a decline in primary care physicians. So these are your internists, pediatricians, OBGYNs. This is not good. This is the core of your public health system, and unfortunately, a decline in dental professions by the year 2030. But even for these increases are not uniform. And so this looks at another great source of data. And I think I may have already shown you some of this data. And I would ask you all to make sure, if you've not done it, click open your community health rankings for those of you who are in the district health departments to see what's going on with your community health rankings. So this shows you sort of some of the discrepancy in physician availability. So you can read on the left faster than I can tell you, but 14 of 93 counties don't have a primary care physician, right? Most rural residents live 25 minutes away from an or way living 25 minutes away from an ambulance than for all but two other states. Oh, that's interesting. So all but two other states, you're closer to an ambulance than we are. Um, and 16% of Nebraska moms must travel 30 minutes to find a maternal care provider. And in many places now, we have increasing number of maternal health deserts here. Within the state. And this shows physicians, but I could show you the exact same thing for nurses. So rural hospitals have a shortage of over 5,000 nurses. And all of this says is we need to think about care differently in rural Nebraska communities. And I use this slide to actually make the point we need better prevention so that they don't need doctors. So this is my favorite slide to show people on why rural Nebraska needs much more prevention to keep them out of trouble. Because if they do get in trouble, it's really more difficult to get care. And I always like to tack on, and thanks to Alex for including this slide, that when we think about people moving to rural Nebraska and taking care of and living in those communities, healthcare providers, not just for them, but anybody who works there, we need to remember that, 77% of parents are in the workforce, so they need childcare. And while there may be adequate childcare cumulatively in this state, there's not adequate childcare within individual counties. And you can see this lighting, all this red that you see here is shortages of childcare. So there's multiple pieces that you need to bring together if you really do want to increase providers in rural Nebraska. So it's just not an easy, simple solution. Well, maybe we'll pay them more or something. It's much more complex than that. And to me, goes back to the prevention part, is how do we keep people in Nebraska healthy? I don't think the solution will ever be we'll just have more than enough doctors than we need in rural Nebraska. It's not going to happen. It's not happening anywhere else in the United States. Um, so hospitals are core to strong, healthy communities, and I crisscross the state every year, as many of you know. Uh, and one of the things I learned early in my crisscrossing the states is, for a healthy community, you need to have a job, you need to have a school, and you need to have health care. And if you miss one of those three, you will not have a healthy community. Probably soon you won't have a community at all. So hospitals, every dollar spent brings back $1.50 in the local economy. Rural hospitals support one in every 12 rural jobs nationwide. There's about $220 billion in economic economy. Here in Nebraska, 70% of hospitals are rural hospitals. Most of those are also critical care access hospitals. And yes, the majority of Nebraska rural communities are considered medically underserved areas. You all know that. What you may all not know is this part, which is 44% of rural hospitals are currently operating at a loss in Nebraska. And about a fifth of all hospitals are vulnerable to closure. And because of these financial constraints, we've had labor and delivery units closed, behavioral health services disappear, home health services, hospice care, EMS services, hospital-owned nursing homes. All of these things are going away in rural Nebraska because of these economic challenges within those communities for hospitals specifically. And then there's all sorts of national factors that are increasing the challenge for rural hospitals. So rural hospitals are fortunate that they get usually with traditional Medicaid, they get 110% of the Medicaid allocation for an admission. Well, the trouble is there's financial incentives for insurance companies to try to cherry pick people off of traditional Medicaid into Medicaid Advantage programs where they make a lot of money. So the insurance are making tons of money, billions of dollars. But what happens at the rural hospital level is that they're only now getting about 90% of their Medicaid charges when they previously would have gotten about 100% of their Medicaid charges. So that's a significant hit to our community access hospitals. The big beautiful bill is also a significant hit to community hospitals moving forward. Um, so Nebraska alone faces about a $3.6 billion cut in hospitals over the next decade. Remember this number 3.6 billion because I'm going to come back to it in a minute. But a lot of this has to do with new Medicaid work requirements. So the work requirements are people between 19 and 64 years of age. And let's be clear. So only about in Nebraska, 40% of people are in that age group. And at best, 10% of Nebraska recipients aren't in some sort of exempt group already. So most people who are between 19 and 64 who get Medicaid, they are fully or partially working. I mean, this is really a program for the working poor, which I'd like to remind people. Others are in school, taking care of a caregiver, have some sort of health condition. So there's probably 10% at best who don't have a known uh, exemption or haven't gone through the process of a known exemption. So removing these 10% of people is not going to be the problem. Uh, for the most part, the issue is that the requirement to re-up yourself just kicks people off the system and so it's essentially a paperwork disconnect. So you use paperwork requirements that make it difficult for people to re-enroll every 6 months to a year, and then that's how you keep dropping people off of Medicaid, including those who obviously would have been eligible otherwise. Also, in this state, soon there may be a loss of retrograde eligibility, which will also decrease money for hospitals who are taking care of these patients and move it into uncompensated care. Now, Congress recognized the challenges to rural hospitals from the One Big Beautiful Bill, and they created a $50 billion rural health transformation program. And it's an interesting distribution, which we can talk about if you want to. But the point is, they're going to distribute $10 billion per year over the next 5 years. And Nebraska actually did really well. In terms of the amount of money they got. So the average was $200,000, right? So 200,000 times 50 times five, you get to uh, your 50 billion. So Nebraska got a little over their average of 200 million. So if you take 200 million times five, that's $1 billion. That's short of that number. I hope you remembered the 3.6 that they're going to lose for the healthcare system. All right, let's transition to the third part of my talk. So I'm going to talk a little bit about community level activities because this is where public health happens. I used to say this when I was at CDC. I used to tell people that public health doesn't happen on 1600 Clifton Road. It happens with our state and our counties. And I say this now as at the here in Nebraska at the College of Public Health, right? Public health happens not in Lincoln, it happens in the counties. Not that Lincoln isn't important or not that Atlanta uh, wasn't important for public health, but where does public health happen? Public health happens within our communities. And I think it's good to remember that and stay focused on where that tip of the spear is for public health. Uh, so there's a number of activities across the state. So while the state may be and the healthcare systems and the insurance plans are quite competitive, it's really nice in this amazing state called Nebraska that there is no competition when it comes to prevention and public health. And we have a wonderful coalition that includes all of the providers, all of the health systems, call a line, state health department, district health departments, uh, and various NGOs to say, how can we work on a couple of health indicators that improve health at an individual level? And if you get enough people improved health at an individual level, you would see essentially a population level effect within Nebraska for improving healthcare. And when you sort of look at what are those key health indicators, there aren't a whole lot of them, right? So it comes down to about 10, I think it's 12 odd things that if we could get this right every time, we would improve health in your county, in your district, and across the whole state. And so this is in collaboration, obviously, with the health system. Right at the top would be, diabetes and high blood pressure control. If you can get those under control, some blood cancers, some cancer screening, some immunizations, take care of mom and babies, and take care of some mental health issues. And so this coalition has been working over the last 6 or 7 years to try to improve health in Nebraska, initially focused on colorectal cancer and now focused on maternal and infant care. This this I'll be very honest with you. This slide breaks every rule of slides. It's too busy. It's all over the place. But don't look at the words. It's to make one point, in which case it doesn't break every rule of slides. It's look at green. Do you see a lot of green? And the lot of green says that our accountable care organizations are doing better than the rest of the nation, right? So medium green is 75th percentile and dark green is 90th percentile. So we have some of the best healthcare in America, right? And these are objective measures of some of the best healthcare you can get in America. And now I'm going to let me just take you to two of these. So if you look down somewhere here, we have colorectal screening. And you'll see most of our ACOs are at least 80, if not 85% and above in their colorectal cancer screening, which is excellent. And some of the why these are all not at 100 may just be due to data issues. But so that work that we did within the ACOs made a difference to get us to what was the target of 80%. Let's look at diabetes control. So you want a lower number. So you want fewer people with uncontrolled diabetes, and somewhere here, think got to only 2.1% of their population of diabetics is uncontrolled. That is excellent healthcare. So I want to use this to make this point again about all the positives in this state that we can build on to help us be the healthiest state in the nation. I can skip this. This is just a busy slide, but to make the point, this is Blue Cross Blue Shield, that we are trying to work with providers at each individual institution that uses them to get data. So we really are agnostic whether you use Blue Cross, Blue Shield, United, Medica, pick whoever you want, but we want them to provide you data uh, periodically so you can keep track of the health impact of your dollars that are being put into insurance and get them to focus on these high priority activities that we know save lives and save money for the state. We are fortunate in having one of the best HIEs, health information exchanges, in, I think the new term is data health utility in the nation. It has such a great reputation that Sync Health, which is the name of the entity, has been asked by the Secretary of Health and Human Services to be part of this Make Health Tech in America Great Again. So it's a CMS initiative about provider and network participation, ensuring payer connectivity, promoting more patient-facing innovations so they can have access to their own health data. What a great idea. Bringing providers together to make data available, and then obviously using this data for more analytic and to drive uh, in this for their main purpose, healthcare activities, but for our purpose, public health activities within the state. And there's a commission that's been set up under the governor to sort of think about how you operationalize this CMS initiative. And they're working on a unified statewide strategy. They've convening leaders to drive alignment. Uh, and they're providing some oversight, coordination, accountability for work group deliverables. The main deliverables, I believe, for the first year. So they're trying to have something done by July 4th for our 250th anniversary to showcase. And I believe that will be about public dashboards, real-time dashboards about health within the state, probably starting with maternal child health. Oh, okay. So for this section, I wanted to share a couple of examples that highlight you and your work, often in partnership with the College of Public Health, to try to improve health within local communities. So this is again about community-based programs. This is a chronic disease management program that we do with shout out to Two Rivers Public Health Department that we do with Two Rivers Public Health Department. This is a physical activity program that's part of a NCI I grant that we're doing in 4 sites across Nebraska, again, in cooperation with local communities. This is a diabetes program in 2 communities, very focused on data and how does data come together across multiple individuals in a community who touch you if you have diabetes. On track, and this is Healthy Horizons. This is a Sherwood project, and this is about improving prenatal care in our communities. Again, the outcome of interest being how do we knock down that time of first prenatal care visit, which should then lead to lower birth weight and lower preterm birth. So a couple of 4 or 5 different examples for you of the great work that's going on across Nebraska right now. Okay, this is where I end. How are we doing on time? 42 minutes. Okay, I'm hoping Julie's gonna be kind to me and let me finish up my talk. So here's the good life, forged by trust. So let's try to put all these 3 things I talked about together in terms of what's going on in the state, rural health, um, and sort of community-based activities. Uh, so I want to start with acknowledging this fact that nationwide trust in the government is dropping and has been dropping since the Johnson era when it peaked at about 80%. And now you'd be hard pressed to find 20% of Americans uh, who trust their government. And who knows how low this low can go. This is not good for many of us in public health who have relied on public health leadership to carry the water for what needs to happen for public health and to be advocates for public health. So, saying nothing about the leadership at all, just making the point that if they're not trusted, then your message isn't going to be trusted, that they may be trying to help you with. So, this is a problem for lots of reasons besides public health. Uh, and it's not just that we don't trust the government, we don't trust each other anymore. And that is pretty sad. 30% of people are willing to trust their neighbors at this point. So that is also depressing. And if you look at this trust, and then you come to us, the so-called ivory tower folks, scientists and scientific publications. Well, the honest truth is the average reading level of Americans is 7th to 8th grade, right? That is a complete mismatch with scientific publications, which number in the millions every year. And I'm not even sure the mismatch matters because where publications are concerned, because often our population doesn't have access to the publications, which are behind paywalls anyway. But again, not just publications, it's how we talk to people. Are we using the right language for people that people can understand? And the truth is, if you look at what happened during COVID-19, the answer is no, right? Over technical communications, failed to address vaccine skeptics, and lots, well, misinformation, disinformation. But often people's reality did not match the reality on the ground. So you thought things were going fine in your community because we didn't actually show you what was happening in the hospital, where there was too many people in the waiting rooms, et cetera, et cetera. No personal protective equipment. I mean, I remember the time when we were thinking about using one ventilator for two patients. We were so desperate on healthcare. But when you reframe this as less than 1% of people died, uh, then our concern is not matching the reality of most people, right? And we need to make sure that we are matching their reality and helping them understand what the reality may be that they may not see because it's so maybe hidden from them behind hospital walls. And this is a great scientist that does science communication. We're bearing the sour fruit of not teaching scientists and clinicians how to communicate with the public. But I think it's more than how to communicate with the public, to be honest with you. So I hope everybody has seen some version of this slide before. Core principles of crisis communications, right? Be first, be right. Often it's not possible to do that at the same time. Hello. Be credible, express empathy, promote action, and show respect, right? So these are the six cores of crisis communication. But none of these uh, principles of crisis communication aren't are useful unless people trust you. It doesn't matter how right, how fast you are, how smart you are, how empathetic you are. If they don't trust you, crisis communication is useless. So what you need to start with is trust and partnership in your with your communities. And I think we've neglected that to some extent because we often, clearly you are experts at what you do, but you have to start with trust and partnership within your community. And I want to give a shout out here to Dr. King and Dr. Shipman, to Dr. Shipman because he's with Creighton, right? This is about partnering with other people, right, across the state to think about how do you build, and we need more work to think about how do you build trust and evaluate trust within hard to reach communicate populations, and how do you find the right trusted person in that community. So I am trusted in multiple communities. I am definitely not trusted in some communities. So how do you find the right person who people trust to take that message about vaccinations or whatever the issue may be, wear your car seat, go take a walk, maybe eat more fruits and vegetables, right? How do you find that right person? And I show this slide to my students all the time, and I think I may have shown you this in the past. What is the public health system? And unless it's all of, and I like them to walk away with the idea that it's all of these people, right? And that all of these institutions, this is your public health system, right? It's not us. It's definitely not me sitting here in Omaha, right? Or even my College of Public Health, right? Or your local health department. It's all of these entities that make up the public health system. And we need to think about what are our partnerships with these entities to drive public health in our communities for better health. Uh, I also want to remind people, and I'm concerned about this more and more, and I know I try to check myself more often than I would. Uh, Public health is bipartisan, and I think we need to be very, very careful of aligning public health with any single public health, with any single political party, right? I think we've got to be super careful about that. People across the political spectrum, they care about their parents, they care about their kids, they care about dying from heart disease and diabetes and everything else. Um, so I think we need to remember that and not get caught up in the hyper partisan environment we're in now, where you can't even watch a half ball, a Super Bowl game without talking about politics, right? Enjoy the music, go refresh in your guaco dip, and go to the bathroom, right, and come back, right? Everything doesn't have to be about the salvation of the nation. So I'm putting this tentatively as my last slide to you, and I'm calling this Public Health 5.0, but it's the wrong thing because it just suggests a sort of a new version of public health. I think public health needs to be rethink, or I guess the right word is rethought, right? And I think it needs to be rethought by younger people than me. It needs to be rethought by you who are on this call right now is what does public health look like to the American people? And I'm actually a little jealous of you because you get to reintroduce public health to Americans in a different way. So the image on the left, thank you very much, Google Gemini, for that image. It's horrid, but I like it because it shows somebody in a hard hat, and so that's the only reason I kept this horrid image. And it's about action, right? When I like hard hat, yes, it makes me think about somebody working, right? And so here on the left is sort of some of my thinking, and I am glad to have you provide input into this. Is how do we put the public back in public health, right? We can no longer trust top-down protection, right? Say, okay, we have these great political leadership, and the political leadership is going to go out and tell people to do X, Y, and Z. Well, guess what? People don't trust that great political leadership, whatever party it may be. They just don't trust them. And you need to develop your own personal relationships with the community that's trusted. Because going back to like 20 slides ago, when I talked about at the local level, people trust their local institutions. So they trust you a lot more than they trust the people in Washington, right? And how do you take advantage of that to leverage that to better interact with your communities? And some of that, I think, starts with this shift from crisis manager to health architect. I mean, this was a key component of when Dr. Karen DeSalvo and others laid out Public Health 4.0 about, which was mainly about social determinants of health and multi-sector partnerships, but how to reframe our role in communities as health architects, which goes back to that hard hat that I love, uh, role within our community. How do we make sure in our conversations we're decoupling partisan politics from public health, right? So how do we help people understand data as a utility? Like it's like the electricity. There's nothing partisan in data. This is what the data is. This is what it shows. And how are we more careful about open source logic that is available to them so they know why we're doing things, not just what we're suggesting? I think as public health practitioners, we need radical transparency and visibility. So we should be helping to not just discuss local problems, outline local problems, publish about local problems. I think every day we should be solving local problems. And if we're not solving local problems for our community, I really do worry about this future of public health in America. If that's not what we're doing every day, which is solving a problem that is within our community. We also need to be a lot more visible. Farmers markets, fairs, I say, every mall should have a public health kiosk. And to remind people, we're so part of this sort of crisis manager to health architect. We are so much more than infectious diseases and vaccinations and mask mandates, right? There's so much more to public health that we don't talk about, that people still trust us for, that we need to be talking about, right? I just went to a restaurant to get a sandwich. It never crossed my mind that I could get Shigella, for my tuna sandwich. Why did it not cross my mind? Because of the amazing health department I have, right? That inspected this place and made sure that the food was going to be as safe as possible, right? We don't talk about all the hundreds of ways, when they buckle up, when they get their car seats. Heck, I tell people I worried about you before you were born, which is why we fortify vitamins with folic acid, so you grew up with a brain, right? So, pre-birth to death. Public health is part of their lives that they don't see, and it would be great if you can help them see where public health is so much a part of their life and how much they depend on you. And I wanted to talk a little bit about value added communications and how we think about swapping terms. So certain individuals in our current world are really good at language and messaging, and I think we need to learn from them, right? And so, should we be talking about herd immunity, or should we be talking about, let me tell you how you keep your school and business open, right? Should we be talking about mitigation measures, or are we talking about how do I ensure that you can still go around and do what you need to do? Uh, so I think we should be thinking about language also, and how do we use language to unite people instead of dividing people, even when the language we use is correct, right? But where's better ways to reframe that language to really resonate with a broader community and not as a way immediately to say, oh, it's them, right? We can never be the other, right? Because we represent everybody in America. We care about every individual within our communities. I'm sure there's more than these 4 points to whatever we're going to call Public Health 5.0, that you guys are going to call Public Health 5.0. But I'm excited about what, I know I'm the one talking, but I'm the one excited about what you do in communities and what you're going to do in communities. So let me leave it at that. Thank you. I hope I ended on a good point, and glad if we have 3 minutes left for questions. Thank you, everybody.
Thank you, Dr. Khan. On behalf of the Public Health Association of Nebraska, we appreciate your time and energy in developing this presentation, sharing some very sobering thoughts with us, as well as inspiring thoughts for us to consider for our state. And I want to open it up to folks today for questions. You can come off mute if you'd like, put in the chat your questions. We do have one in the Q&A, or at least a comment that you might want to respond to. I would assume the childcare availability doesn't include unlicensed care. I would be interested to know the source of the data that you provided.
Hi, Katie. That's a great question. Thank you. Yes, it doesn't include unlicensed care. Obviously, it would only include licensed care, probably based on licenses. If you look at if you could, Julie will share these slides with you. Anything I share publicly becomes public, and you can go to the county health rankings and go look at what the exact data source for that is.
Let's see if we have any other comments or questions. I have a couple to end us out.
Oh, wait, hold on. I see Dr.
Okay, you do?
Keeler.
All right.
Yes, Doctor. Oh, Dr. Keeler, you're the one who should answer this question, not me. You're such an amazing communicator. So she's absolutely right. We do not train clinicians and providers on how to tell stories, and we need to be better at telling stories, right? The reason it's invariable, right? And I see this happen all the time, right? So public health goes to a legislative group to ask for money to save 1,000 kids from measles or whatever, and they need, so many dollars to go reach all these kids, and they're not going to get sick. And then somebody from the healthcare system shows up and goes, I need $1 billion for a proton pump inhibitor thingamajiggy Death Star to save 2 people. And people are like, oh my gosh, yes. How much does that Death Star cost? We need to get you one of those because we got to save these 2 people. And I want to save those 2 people too, without a doubt. But we don't tell a good story about that kid that's not in an iron lung, or whatever the case may be, or that isn't deaf, right? And so all need to be better storytellers. And I would suggest that whenever we're asked a question, and I need to get better at this myself, I often launch immediately into data. Measles vaccine, 98% effective with 2 doses. Maybe I should launch into, my cousin Johnny, who's deaf, was deaf because of measles. And now, guess what? We don't have all these deaf schools in America, right? So I think so Dr. Keeler, you're spot on. And that, I think that should be a challenge to everybody here, is how do you answer a question in your field that starts with a story before you start with the data?
Thank you so much. I think you're hitting on this question, but I would like to know, how can we balance empathy with accuracy when addressing misinformation?
So this is one I still struggle with. So the honest truth is, misinformation is disinformation, misinformation is a fixed belief, and it's not subject to change. It's like religion. It's like somebody coming up to somebody who's Buddhist and saying, I got this great new religion from you. And they're like, yeah, I'm kind of good with the Buddhist part, right? So you can never approach it with data. and your facts, because they've got their own data and they've got their facts and they've got their experts with more MDs and PhDs and things behind their names than you will ever have. I think the only way to approach this is with empathy, right? And to find the common thing you share with this individual, right? I don't think I will ever come across an individual who will say, you know what, I think iron lungs for kids were a good thing, right? And maybe that's a better starting point about what you care about, your own children, your family, your neighborhood, than the fact that let me tell you know that polio includes SV40 virus that is going to cause cancer for everybody, right? I think starting the conversation there at the piece of disinformation, you will always lose. But if somebody's got a good answer to that question, I would love it because I struggle with this all the time because I see the craziest stuff show up in my feed.
Yeah, I would agree. And I think a lot of us on the line probably have some great ideas about how to activate just around this or other things in public health. So for those of us who are still on the line today, feel free to chat. What's one small action you can do over the next 12 months in relation to what Dr. Khan has shared with us today? That could be a many things. So feel free to share with your colleagues here. We have lots of folks on the line, and we'd love to hear from you. And then I might just see if there's other questions before we end today. All right. I will be sharing out the slides as well as we have a recording for folks who'd like to review some of the things that Dr. Khan had shared with us today. And Dr. Khan, do you want to end us out before we leave today?
Oh,
You have
thank you.
some
That's very.
words of wisdom?
Oh, I still get a last word after all
You
that.
do. Yes.
What you all do in your communities matters, and it matters more today than it's ever mattered in the past, given the chaos we're seeing at the national level. Okay? So please use and build your local relationships to improve health within your communities and let them understand what vital role you play within your community. So that's my last words of wisdom for you.
Thank you so much. And thank you to everyone who joined today and took the time out to listen to the message. Have a nice day.
Thank you all.